Hello, everyone. I have 12 o'clock Central Standard Time, so we'll go ahead and get started. I'm Sarah Francis. I'm with Iowa State University and am the Research Director for the Nutrition and Aging Resource Center. I want to welcome you to the Nutrition and Aging Resource Center's webinar, Placing the Value in Evaluation, Practical Tips for Measuring Impact. We are excited to welcome Shauna Marceau. Shauna brings more than 15 years of experience in the position of nutrition services to some of the most vulnerable community members in Austin, Texas. In addition to overseeing a commercial kitchen producing approximately 3,500 meals daily, including medically tailored diets, Shauna also develops and implements evaluation methods to objectively allocate limited resources, prioritize services, and measure programmatic impact. Healthcare system approaches that address social determinants of health, which positively impacts health outcomes, saves the healthcare system and taxpayers money, as well as helping people live with dignity and independence in their own homes. Shauna has a Master's of Science degree in Human Nutrition from Texas State University and is a licensed and registered dietitian nutritionist. Her work has been published in the Journal of Nutrition, Health, and Aging. Shauna has been honored for her commitment to the ideals of scholarship, leadership, and services by the National Society of Collegiate Scholars. She has also received awards for innovations in dietetics practice and education by the Academy of Nutrition and Dietetics, as well as leadership, research, and academic excellence by the School of Family and Consumer Sciences, Nutrition and Foods, Texas State University. During today's sessions, Shauna will discuss why evaluation is important and how it can be used to objectively prioritize limited resources and how to get started. Before we get started, I want to mention some housekeeping items. First, we will hold questions until the end of Shauna's presentation. Our team will be monitoring the chat and the Q&A throughout the session. Please write any questions you may have here. We will start the Q&A session with the chat questions first. You can also raise your hand using the icon and ask your question orally. At the end of the Q&A session, we encourage everyone to complete the evaluation that is accessible with a QR code or the link that will be placed in the chat. The information you provide will help us during our next webinar. The Nutrition and Aging Resource Center is continuously working to improve the accessibility of events and content. Automated closed captioning will be provided for this webinar. Participants can enable captions by selecting the CC in the toolbar or closed caption in the meeting options. This webinar will also be recorded and made available on YouTube. The video with captions revised for precision will be shared via the Resource Center's newsletter. If you have any questions about captions or additional accommodation requests, please email nrcna@iowa.gov. Finally, we did not seek prior approval for this event for CPEU credits for dietitians. You can still receive credit under the CPE activity type 171 teleseminars webinars. Please visit the CDR website for further instruction. Shauna, I will now hand it over to you.
Wonderful, thank you. I'm really excited to be here. It's truly an honor. And I'm incredibly grateful to be able to speak to this group today. So hopefully I can share something of value to those attending. I'm going to share my screen with the presentation. All right. I am with Meals on Wheels Central Texas in Austin, Texas, and as was mentioned, I've been in this network for 15 years and really excited to present to you all today. What's exciting to me about this webinar is this is about measuring success and how do we know we're making a difference as nutrition providers. There was a special supplemental publication from the Journal of Nutrition and Gerontology and Geriatrics in 2015, and that entire supplemental journal is all centered around home delivered meals, and so that was really exciting for us to see at that time. And the paper that kind of drew me in was by Thomas, And the title is Outcomes Matter, the need for improved data collection and measurement in our nation's home delivered meal program. And the article discussed how there's a lot of justification, or the justification for funding has moved from the concept of doing good in the community. And there's definitely a lot of philanthropy work and a lot of philanthropic support for organizations and agencies like ours. But it is really moving from that concept to more of providing a portfolio of investment to the funder's board of directors. There's a lot of programs that they can fund, or a lot of agencies they can fund, but when a program can demonstrate their outcomes and demonstrate that we're good stewards of the dollar, that actually creates, we add to that portfolio of investment for those funders. And so it reduces uncertainty and therefore risk, and creates value to our stakeholders. So the whole concept was, and many of you might have already heard this, that we need to find a way to not move away from experience-based evaluation. So these are, are they eating the meals? Are they satisfied? The satisfaction surveys and self-reported aspects of improvement. Those are all still valid approaches to evaluation, and we don't ever want to get rid of those. It's a piece of the puzzle, but we do need to find a way to also transition to more measurable outcomes. Things involving how are we measuring whether their health improved or their functional abilities, and any other healthcare related outcomes. So why do outcomes matter? It tells us what we're doing right, but it also tells us what improvements are needed. And this can also lend itself to new funding possibilities. If you look at the little quote in the dark box, I loved this quote because this is really how we need to start thinking, that the quality in a product or service is not what the supplier puts in, it's what the customer gets out. So we're very
Sienna,
much.
I don't mean to interrupt you, but it looks like our slides here have frozen
Oh,
on the meeting side.
okay. Let me stop sharing.
Yeah, you try.
And try again.
That's...
Oops.
All right, now that looks like the slide that you were talking about. Could you give me kind of a back and forth? Make sure those are changing for us. Yeah, okay. It looks like it's all fixed. Sorry to interrupt. Just wanted to make sure that.
No, thank you so much. Did everybody see this one? Okay. So when we think of, we all provide a product or a service in our industry, whether it's the healthy meals that are delivered, the product is the meal, the service is the delivery to the doorstep, for example. And so oftentimes we talk a lot and report out a lot on those outputs, the number of meals produced per day, the number of clients on our rosters. And that is really important information. Outputs are very important, but true quality in what we do and what impact we can make on the community isn't really reflected in that number. It kind of shows the scope and the breadth of our work and who we touch every day. Outcomes are more of something that is measured, and that what is that impact that our organization has on, for example, improved nutrition status or food insecurity, or maybe it's a depression scale or social isolation scale. But one example, so again, outputs can be, we produce 3,000 meals a day, but the outcome can be how many people improved in nutrition status in just 3 months of meals. So really a measurement showing what did those meals actually do? So what do we measure and how do we go about all of this? Well, the roles of providers in meeting older adults' wellness needs, specifically the foundational purpose of the Older Americans Act, which is what I operate under. Many of you, I see there's a lot of those from the AAAs and different aging networks. We follow the Older Americans Act. That's where we were founded from originally. But the whole purpose is to reduce hunger, food insecurity, and malnutrition in older adults. Malnutrition is highlighted in bright pink here because it wasn't until the 2020 reauthorization of the Older Americans Act where we got to see the word malnutrition as being a true purpose that we're trying to prevent or improve malnutrition. So a lot of my research previously was done in malnutrition, to sort of finally see it on the stage with the Older Americans Act is really helpful to me. But if we're also promoting socialization of older adults and other health and well-being aspects, these are the things that is our foundational purpose. So these are the things we want to look at potentially measuring. So if we look at the impact of meals, so for the past several decades, there's tons of research, papers published from the 80s and beyond, really looking at nutrient intake and how it's lower in homebound older adults compared to older adults in general, or how on the days a participant receives a home or does not receive a home delivered meal, how their nutrient intake is so significantly lower, or how they are at higher risk for poor nutrition status. We do know that, I mean, what's highlighted in blue there is no question amongst any experts in the field nationwide that the home delivered meal contributes markedly to a participant's intake. So that's great. But what we're seeing now is, or just over the past decade, is more work being done on showing whether we impact, like I said a moment ago, malnutrition, food insecurity. Now you're hearing a lot about social determinants of health and how food insecurity is related to high expenditures. We know malnutrition is, but how can we show that we can impact those expenditures, which is a win-win across the board? And then we're also seeing some work done on do our services help with chronic disease management? So this is kind of like where we are headed. So measuring impact on malnutrition is where I'm going to start. This is going to be one of my real life examples. I'm starting with one that's quite the gusto. So I am going to ask a question in a little bit because I would love to hear what everybody might say. But I want to start here, and I want to introduce everybody to the MNA, Mini Nutritional Assessment. This is the only nutrition screening instrument that was specifically designed for the older adults in mind. So it was validated on a 65 plus population. And it has all the components that we really need when evaluating the nutrition status of an older adult: food intake and unintentional weight loss. We are kind of trying to get at frailty and functionality, recent hospitalizations, depression, dementia, or any other stressors. And then what makes this one so interesting is there is a body composition measurement. You can either do a measured BMI, which is not appropriate for a community setting, which is what I'm in. And you can't use self-reported. You can't say, well, how tall are you and how much do you weigh? There's literature supporting the fact that self-reported height is overestimated in older adults and weight is underestimated. So we opted for the calf circumference. I know that sounds strange, measuring the circumference of a calf muscle in an adult 65 and older. If it is under a certain centimeter, that is indicative of functional decline. When we don't get the nutrients we need, we will start to lose muscle, and we're going to lose it in our extremities first. So the calf muscle being an extremity, and it is that indicator. And again, functional frailty and mobility is really key in remaining independent. What I wanted to say about this one, it was validated against, they had two physicians, and this was in the 90s. So they had two physicians who specialized in diagnosing malnutrition in older adult populations. And they had these, they used the MNA, which this is the short form. And they have a long form that's in a clinical setting, like 3 pages long. So that's the one, this is also validated, but they started there. And what they were able to show is that the groups of patients, it was patients in this case, that were identified as malnourished by the physicians, that the MNA identified those same people at a very high percentile. Those individuals that the physicians said this is an at-risk individual, or this person is at normal nutrition status, which is the term on the document, so good nutrition status, the MNA was identifying those as well. So that was a really good sign. So lo and behold, they created a short form that could be used in a community setting. Now, it's not written that way. It's written very clinically based. So I worked really closely with Nestle. I asked permission to modify their training guides that support this tool, and to make it more for a community setting where you have assessors in the home that don't have any health care background or anything. And we've been able to successfully do that. So this is, she's now my director of impact. She's an incredible master's in public health epidemiology person. And so this is her conducting the MNA in the home and measuring the calf circumference. So here's like the really great things about the M&A. The full M&A, that long one, is validated and considered the gold standard. So again, it was measured against MD assessments, biochemical parameters, which means blood work, and anthropometrics, which means measurements. It's extensively tested for validity and sensitivity, all these fancy words. Like, it is awesome. When we look at the word sensitivity and specificity, it means a lot to, I mean, the other, reliability and validity are really important. But what those mean are, if we've got 100 people and we need to know who of this 100 is malnourished or at risk and who is not, the M&A is really, really good, high 90 percentile to finding those that truly are malnourished, that really are, according to the clinical setting. But that's sensitivity. But specificity is, can the M&A also identify those that are not malnourished? And a lot of tools out there overestimate risk, but the M&A has very high 90 percentiles in this area. So it is considered the most appropriate for older adults in the community setting. I want to highlight this tool. We all know this tool, the Nutrition Screening Initiative. We call it, so in my papers it's NSI, but in our regular work in internal operation, we call it the Nutrition Risk Assessment. I'm not sure what you all do. This is mandated for everyone to do, and it was developed by incredible groups. So what's beautiful about this tool is that it's really good at identifying risk factors. So risk factors are factors that can put someone at risk for poor nutrition status, but it doesn't mean that they are at poor nutrition status. So this was really developed as an awareness tool for someone even to fill out themselves and take to their doctor or to a dietitian for some consultation. But it wasn't meant to flag malnourishment or poor nutrition status, and not meant to be an evaluation tool to see, do things change from this tool. But we've used this to develop a lot of our nutrition education materials, which is perfect for the older adult population, because these are the legitimate risk factors that we face as we all age. So let's just dive in a little bit more, because the reason why I'm bringing these up, by law, regulation, we all need to do the nutrition risk assessment. So if you can imagine how difficult it was for me to add something to the plates of everybody rather than take away, because I couldn't take this one away. So I just want to talk about the differences here. So the pros, it's widely used in all of the home delivered meal programs. So we can compare programs. What is the provider in Austin, Texas? What does their population look like when it comes to high risk? What is that? How does that compare to in Iowa, right? So you can compare your populations. Again, risk factors for educational purposes, and it's quickly administered. It's 10 yes or no questions. But there are some cons when it comes to evaluation, not other purposes of the tool. It's not validated for that, low specificity. So that means that it's still, those people that are not malnourished, it's still going to mark them as high risk because they're an older adult and they're likely facing a lot of those things. So the question is there uses beyond education? So the M&A, these are the pros, which I already listed on the other slide. But I'm sure most of you on here thought, as soon as I said you have to measure something, your red flags went up, right? Well, we had all kinds of red flags at our organization when I was first trying to implement this. It does require training. You do need to train the assessors or the support staff to do a valid calf circumference measurement. And of course, then you have to measure the calf. So what I want to do next, before I jump in, I'm just curious, and you feel free to use the chat here. Let's pretend you wanted to implement this. What type, or maybe you wouldn't get any pushback, but if you would get pushback, what do you see wrong with this tool? What would make you concerned about going back to your organization or agency and trying to implement this? I'm curious. So if y'all can put that, what barriers or hurdles you might face at your own internal organization if you were to try to implement this. And as those responses come in, I will let you know when this says Research Project 2010. So yes, this was thesis work 13 years ago with both of these tools, my own. And I've been through some of the difficulties. So I don't know if we have any takers on anything they think about it. Usually people feel very strongly about the M&A in a community setting. Who has time to do it? Capacity, who's going to do it? Timing of getting these done, significant workload, shortage of staff, extra forms to fill out. Yes, like we keep adding things, right? We're not taking things away. Totally understand that. Yes, all of those are very similar. So, there we go. So what we did is we did a little pilot. Well, no, this wasn't the pilot. This was actually what the research itself showed. So we had both tools, the M&A short form and the nutrition risk assessment. And before clients got meals, we measured them with both tools. And we showed that almost 78% of those in this pilot were identified as high risk by the NSI, but only 13 were identified, or 33%, as malnourished. And so what that's already going to show you is you can see then right away, those are the same people that NSI is just overestimating that risk, and that's okay, because that's what that tool is supposed to do. So these tools, the purposes of these are different, but 3 months after meals, it shows that our meals didn't really improve for anybody's situation. Most of the people, still 70%, are still at high risk, and that's because our meals can't impact whether someone eats alone, can't impact whether they have chewing or mouth difficulties, can't impact whether they take more than 3 medications a day, those are all things that put us at risk. But our delivering the meal can only probably modify maybe 1 to 3 questions on that tool. So before meals, malnourished, 33%. After 3 months of meals, look at how many less people are in the malnourished category, showing you that growth and that our meals are moving the needle and making a difference. So now let's look on the good side, quote unquote. I'm using quotes from the tools, the good or normal nutrition status. Before meals, it showed none of our clients being at low nutrition risk. After meals, it showed only 2 improved to get to that level. Whereas at baseline, the M&A was able to show that 20% of the people were in normal status. So again, that's that specificity. Who's really doing all right? And then after meals, look at how many jumped up to a normal status. I mean, completely changing the category from a validated tool. This was really exciting for all of us to see in 2010. So I say all this because, yeah, all right, that sounds great. When I heard about it, I was like, oh, yeah, this sounds great. This is in academia. This is evidence-based. It's validated. But a lot of times what we learn from the academic research setting, it's really hard to apply in a community setting. This is really where that rubber meets the road. And what I've been trying to serve, and my team to serve, is we in our area, we are that bridge, because we can, rub elbows with academia, but we're also grounded in the community setting and know that not everything looks a certain way and is that easy to pull off. So this is what I did, because I was petrified. I had just started. It was 2008 when the economic downturn happened. We had our first waitlist ever. And this is what put me on this pursuit, is like, how are we going to find out who to put on first? And so anyway, so I learned about the M&A. I'm ready to implement it. And this is the pushback I got right away. We're not medical professionals. They already confuse us with the nurse, and that's not who we are. This is only going to confuse clients more. And if you could only imagine the calf circumference, what if the client has weeping wounds? What if there's amputations? What if the client's not comfortable with the measurement? What if I'm uncomfortable, as a case manager or an assessor? And increased time. So a lot of the comments you all put in there were all about the increase of time. Who's going to do it? One more thing. All very normal gut reactions. I felt the same way, and so did the entire team at my org. So this is what we did to try to get buy-in. So first of all, you do have to have support from your senior leaders, for sure. At the time, I was not a senior leader, but I did get that support. So this is what we did. I asked for 3 assessor volunteers, and I said, let's pilot this for 3 months. Who's willing to try this and administer both tools for me? And this is what we're going to do. We're going to time both of them. We're going to ask the client's permission first. We had a script. our script said, Miss Olivares, the next thing I want to do, I need to measure your calf muscle. And the reason why is when we don't get enough nutrition, kind of what I mentioned earlier, when we don't get the right nutrition we need, we start to lose muscle. And we're going to first start losing that in our legs. So may I measure your calf? If a client says no, then you don't do it, and that person won't be in the data set. But most of them were very comfortable with that. So then after we did it, we asked the client on a scale of 1 to 5, how comfortable were you with me measuring your calf? And the case manager or assessor also got to document the same thing. We had 60 clients screened total in these 3 months by these 3 people. The client comfort level, 5 was very comfortable. It was 4.4 was the score for those 60 clients, really demonstrating to my staff inside, our staff, okay, your pushback is not because the client's going to be uncomfortable. Only 1 client felt uncomfortable with the calf circumference afterwards, out of the 60. Case manager comfort level, that's where I found very interesting, because there was one of those assessors that in the very beginning, every Likert scale was a 1, 1 meaning I'm not comfortable with this at all. I don't want to do this at all. By the end of the 3 months, she was completely comfortable with it. So sometimes it's getting used to change, something new, and things like that. And then of course, here's the average time spent, about the same amount of time. When you really look at the time, it's not a whole lot. Now, I'm very familiar with all the data we collect in the home, all the requirements and the things that we do on top for evaluation work. So I understand every minute counts, but when you really look at it, you have to ask, is the juice worth the squeeze? And what we found is it is. So, these were our pros in implementing the M&A at Meals on Wheels Central Texas. The pros were, well, it's more specific. It takes the same amount of time, and it's now used in program evaluation. So it is our #1 metric for all funders. We've gotten to where our funders really want to see that one. And we've had to limit a program. We have a second meals program, for example, a breakfast program that we can't provide to all of our 2,000 plus clients. We only have funding for a small subset. So how do you determine who gets that? These tools can be used for that. Cons, it's only used on those 60 and above. So we have younger clients because of the physical mobility and disabled aspect. So the M&A is not appropriate for them. It's meant for older adults. So it's only for that section of your population. And if you don't have a calf circumference, you can't score the tool. That's how validity and reliability work from a robust evaluation of a tool. Because I tried. When I first learned there's a calf circumference, I thought, there is no way I'm going to get anybody to do this. Can I do it without it? And it was nope, nope, nope. And the other con is, like I said, it's not going to replace what we already have to do. So this is an add-on. So, in 2019 was the last full year of the data set because of the pandemic, because of the required in-person visit for a measurement. But this is what our process looks like, and we're excited that it's back underway again. So before meals, those 60, 65 and above had the M&A administered to them by all the assessors that are going in the home and doing the C&E. Then if they're eligible and they get on our meals, our hot meals, medically tailored, that is, are delivered with human contact, which is important. And 3 months later, my staff would go out. So when I say that, I'd have dietetic interns, we'd train them and have them go out. We had very limited staff. I've been out and done this, but in just 3 months, 2 out of 3, and this stat held true for about 3 to 4 years. 2 out of 3 new Meals on Wheels clients who were malnourished or at risk at baseline improved in just 3 months. Malnutrition in older adults leads to longer hospital stays, premature institutionalization. They're not going to heal from their wounds very well. If they get sick, they're not going to rebound as well. Our protein stores are our immune system. And when you're malnourished, you're going to lose a lot of that muscle mass. And so malnutrition is probably one of the biggest indicators of frailty and then institutionalization, especially that composition of the body tissue. So to me, I thought we are collecting evidence showing that we are not just a service or a product. This will create a clinical outcome. They're starting now in the hospitals to identify malnutrition more, realizing that this is such an under-discussed issue in our older adult population. It's a hidden epidemic, and there's a great YouTube video on that. You can look that one up. So the bottom line, the MNA is strongly supported by research in identifying malnutrition. It's a more sensitive indicator of change in nutrition status, and it can help with prioritizing those most in need. And it's a metric now widely desired by our development department and our funders. We were published in 2018, continuing this work, working with the San Antonio Meals on Wheels and UTSA there, showing that, I mean, for us to be able to say that a Meals on Wheels program significantly improves nutrition status, significantly here is statistician measured. It's not just, I mean, this means a lot. This is a big deal. So that's malnutrition. Now that's my most robust tool. So that's the one that scares people off mostly, but I hope that I showed you that. Sometimes you kind of just offer it as a pilot and just ease your way in and then see. I do have some failures. I'll share those with you later, but you just never know. Food insecurity. This is easier to measure because you can do this over the phone. We use the USDA Food Security Survey, the household one. It's 6 items. It's also validated. Here's the questions that are asked, and it scores it for you. The reason why I have the last question highlighted in blue is because sometimes I've been asked, my development department, or some funders want to know how we are addressing hunger. Well, hunger and food insecurity, while related, they're not exactly the same thing. But if you wanted to just report on we improve hunger, that last question can be the only question that's a positive or a negative and that you can help. So you can frame an evaluation in being as simple as one question and it still be meaningful. But what I love about this tool is it's not a yes or no. It's not a yes they are or no they're not. It's a gradient. The scores are 0 to 6, and 2 to 6 means you're food insecure, with 5 and 6 being the worst. This is the one we actually use now to prioritize for that breakfast program I was telling you, because we wanted to include all clients in that, older and younger. It was, in fact, when we actually had funding cut, we had to cut this program in half, about 300 people cut off of it. Nobody ever wants to be in that situation. It is incredibly hard to do in the settings and the passion that we have in the work that we do, but you do have to make these decisions. So I highly recommend you find a validated instrument to help inform that. And this is what we use to make those decisions. The food insecure individuals stayed on the program. Those that were not food insecure were removed. And then once you get a wait list, then you can prioritize it. Those that are a 5 or 6, 6s should go first. And this is how we do it. Now this will fit into all of your natural operational things, because the M&A 3 months later, resources. You need a human to go out and do this. So I understand that's not everyone's able to do that. But this should fit into your recertification cycle. Before meals, we administer the USDA Food Security Questionnaire Survey, FSQ is what we call it internally. And then hot meals are delivered with human contact. And then at the 1-year recertification mark is when those questions are re-asked. And we're able to show, well, first of all, prevalence of your population. How many in our population is really food insecure? And after 1 year of those new people, 1 year of service, do we move the needle on that? And we do. We do. New enrollees identified as food insecure in FY20. So there's 51 people that started on our program in 2020 that were 51% were food insecure. After 1 year, of those 51%, 83 improved. Food insecurity is the leading social determinant of health, and it is being connected with all types of healthcare expenditures, poor quality of life. I thought I might have had the slide next to it that shows just all the reasons why, if you're food insecure and you have mobility challenges, which are our clients, it's a strong predictor of institutionalization. So we're hitting on some things that are really upstream. So those are the two tools I was going to share with you today. I want to share with you some others. Healthcare is starting to use this one and some other community-based programs. I mean, maybe you don't want to do 6 questions. You want to do the hunger vital signs. It's only 2. But this is a black or white. This is a yes, you're food insecure, or no, you're not. So it can be limited. But if you have a small program, that might be all you need. From a malnutrition aspect, there's a lot of malnutrition screening tools. This one is only 2 questions. But this was validated in an acute care setting, which means hospital or clinic. And it's meant for any age. So it's, are you losing weight without wanting to, and are you not eating as much? Both of those questions are in the M&A, but again, that M&A is bringing in mobility, frailty, chronic condition, like were you in the hospital, really just honing in on older adults. But if you aren't able to do the calf circumference, could you use something like this? Pilot it. Why not? And this is all self-reported, so you're not weighing anybody. I think this is so cool. This is a new paper, 2021, Journal of Gerontology. New food security screening just for older adults. So this is fresh off the press. I mean, it's 2 years, but it takes a while for research to get to regular society in a way. This one is recognizing that, and we've seen this internally. It's like you ask that USDA food security questionnaire, and it's not hitting at what might make an older adult food insecure. So, for example, it's not hitting on the, an older adult might show as food insecure because they cannot get to the store to purchase it, or they don't have the mobility strength to do so. So this new tool developed by these researchers, oh my gosh, that might be the same Thomas right there. I don't know. That is the same Thomas in my other paper. Cool. I think there's a whole nother one now that's meant just for older adults. It's been validated. I think it's going to need to catch on. It'll be interesting to see what the USDA does with that. We're not ready to implement it yet because we're trying to do some other things, but this is on our mind. And from an equity standpoint and cultural appropriateness for all groups, I had a grad student rotate through, a nutrition grad student, and this is her thesis work. It's really looking at the USDA Food Security Survey and if it's culturally relevant to all groups. And what they're showing is not necessarily so. So here's some of the quotes from the article, and of course I've added the link for you to read it as well. It may result in misunderstandings of the survey questions and data that do not quantify the full extent of the food insecurity. For example, respondents from Latinx households report that running out of food is not an issue because there is always something to eat, they say. So again, if you're in a culture where you may not perceive that you're running out of food, you may not perceive that this is putting you at risk because it's something to put in people's bellies. That shift, we need to really inform these screening tools to be more I guess, appropriate and more relevant to different cultural groups. So this disconnect can lead to underestimating it. So I think, it'll be interesting to see what surfaces over the coming years. I wanted to share this with all of you. This is also fresh off the press from a colleague, Dr. Sehun. This is free. All of these are free, by the way, online. So if you just Google expanded food security screener, find this, there's a guide on it. It's a validated prioritization tool just for home delivered meals. So if you have a wait list or you don't know how to bring people on ahead of others or like how to order that, this is something to look at, because so the food insecurity questionnaire is in there. FSQ is in there from the USDA, and then they're going to have some other things on accessing groceries or the ability to cook. And then this whole, to the right of the screen, there's your priority levels, and it helps you make decisions. Again, find tools to help you make these decisions, because it's really hard to do subjectively when we want everybody to benefit. And my last slide topic, so we can then open it up to questions, is I wanted to share a quick tip. A descriptive statistic for your population. So for your grant writers, or if you're out communicating an ambassador for your program in the community, some programs are income required, and there's a certain SPL that's set nationally. But when you really look at economic insecurity, it really depends on where you live. I live in Austin, Texas, which I couldn't move here now if I wanted to. I got in early before things got really crazy, expensive wise. So when I'm talking to my funders, I'm not going to talk about 100% FPL, because to live in Travis County, it's higher than that. So I'm so excited to share this with you all. This is called the Elder Index. The Gerontology Institute at the University of Massachusetts, Boston developed it, and it estimates the minimum amount seniors need to meet monthly expenses based on your county, your household size, your housing, and your health status. So if you've ever reported your percent of individuals you serve that are low income or living in poverty, this could be an excellent tool for you to use. And you go to this website, and it's a filter, and it's 2 steps. You choose your location, and then you choose your filters. So you can look at, all right, if they're single and a renter and in good health, what is the amount of money they need to live in this county to be economically secure, to live independently? So what we did is we toggled with each of these to create a range for us, and that helps us now describe to all of our external stakeholders the FPL, like what we define as poverty in Austin or Travis County, which is going to look different than Silver City, New Mexico, for example. So I wanted to share all of this with you all. So my action item before we open it up into questions is explore the use of a tool to measure food insecurity or nutrition status if you're a nutrition provider of some kind. Look at the operational workflow of onboarding it, what can be done on the phone, and where in the process would this data need to be collected. Discuss it with leadership, get their buy-in. Feel free to conduct a feasibility study or pilot. That was that 3-month pilot. So you can learn. And with that learning, you often gain buy-in. And most importantly, don't be afraid to fail. Fail forward. I'm sure we all fail forward. When you fail forward. And I think that's really important that we all understand. When I implemented the M&A, I also implemented Screen 2, which is a validated nutrition risk screening assessment out of Canada. I implemented that at the intake, so when people are first onboarding, and then I implemented the M&A at the assessor level. The M&A showed to be successful. Screen 2, not for my population. Every single, I had the database changes done. I probably should have piloted that one. That one, I ended up having to strip it from our database. We put it in there, and it showed basically everybody showed up at the same high risk level. We couldn't do anything with it. So it depends on your population. But so I've had failures with this, but that's the only way you learn and move on. I've had more successes than failures. So that's all I wanted to share. So I'm happy to take questions. This is my contact information. Please save my email. Feel free to reach out. We're building a big evaluation and impact arm at our organization right now, and I'd be happy to help with any of this. So I'm going to stop sharing and let you all take
Thank you, Shauna. That was a great webinar. As a fellow evaluator, you were speaking to my heart, so I really enjoyed it, and reading the chat, so did everyone else. And if you look, you're getting applause. So now,
cool.
and a heart, you got a heart emoji. So now we will take questions, and there's a couple. There's one in the Q&A that I'll start with, and I think you did touch on this during your presentation. But the question is about the MST, and what about using how does it work in the older adult population? So you did mention that it wasn't tested with older adults, but if you could expand a little bit more.
Yeah, good question. First of all, it's a validated tool in the acute care setting. So it could be used on an older adult. It could be used on a 20-year-old that's in a hospital clinical acute situation. I don't know how it measures. Oh, I guess of the papers I've read, it comparing the M&A with the MST, the MUST, there's all these other ones. The M&A is the only one that's meant for older adults. Now, that doesn't mean that's the only one you can use. If you are interested in something like that, I would pilot it. I would pilot those two questions. What does it show in your population? But I wouldn't do it at the annual research. Malnutrition in an older adult, like we all know that a lot can happen in just 1 year of an older adult's life. And even though we do the FSQ that way, the MNA, the malnutrition piece, that 3 months later, we saw an increase in calf circumference. That's muscle mass building. And we had a grad student come and look at 5 years worth of data, and it was statistically significant how after 3 months of meals, it increased the calf. So I don't even know why I got on that. I just had to throw that one out there too. But I would implement it, pilot it, find two people, and I would, you'd have to probably have somebody, and it can be on the phone, so you could do it on the phone, ask those two questions, and I would call 2 to 3 months after meals. I wouldn't go beyond the 3 months. Before I implemented this and to capture that 3 month, I talked to some home health dietitians that were using this, and they say, the 2 to 3 month period, you will see a change. We do 3 months because that's how the tool's written, but it would not hurt to try it. And you should try it and see. And then I would love to know if you do this, whoever's asking that, I would love to know how it turns out, because that's a lower hanging fruit. I understand the M&A is a little bit tougher one, but let it marinate. Think about it.
All right. I want to remind our participants that you can unmute yourself and ask your question orally if you do not want to put it in the chat. We have about 12 more minutes for Q&A. So please submit your questions via chat or unmute and ask it directly.
Just a quick correction there. They can't unmute themselves, but they can raise their hands, and I can unmute them.
There you go. Thank you, Spencer. That is why you are here, to keep us all aware of what we can and can't do with Zoom.
And I noticed, like most presentations, a lot of questions may not come at the time. Feel free to email me after. I'm happy to have a conversation with people too at a later time.
We did get a question just about, like, if you would send the slide presentation. We will be recording it, so you will have access to the full presentation in that regard instead of the individual PowerPoint. Any further questions? Here's one. Great presentation. Do you consider other factors in the calf circumference?
No, and only because that tool is already validated, and the amount of evidence behind it removes any question or doubt that using those questions with the calf circumference measure is just as good as using those questions and the BMI. And calf circumference is much easier to do. And that measurement, that would be an anthropometric measurement that physicians would do to also help inform a malnutrition diagnosis. So I think from a lean muscle mass loss standpoint for older adults, it's a really great measurement. But just because someone's calf circumference is below 33 centimeters it's not a diagnosis. It doesn't mean they're malnourished. It's how everything in that tool hangs together, because some people are smaller stature. And it's not perfect. You might have a person with a calf circumference of 56, and that's known as sarcopenic obesity, when you might have some other tissue there, but it's not really measuring the muscle, or you have edema, swollen legs. It's not perfect, but it's really good for what we've got to use.
Shauna, we have a couple questions in the chat. First is, do you have any tips for tracking data or just Excel, something we might not be thinking of?
Oh, that's a great question. We started out tracking a lot in Excel. until we migrated databases, and then we can kind of get the data points in that we need. A database would be the best, because then you can develop reports and query for this information. But if you have a good Excel user and you don't have thousands of clients, you know, if you need somebody with good Excel skills to be able to do analysis in it. But Excel, we love Excel. So, but definitely a database is recommended in some ways.
One question is, can we access your training tool for the M&A? That's from.
Yeah. Okay. So if you send me an email, or how do you think we should? Because there's the M&A, which is available online, but the training guide to help train someone how to administer it. If you find that online, it is clinically written. I have the one that's community written, and I'm happy to share that. I asked permission, it's documented. We're good to go with sharing that.
Shauna, perhaps you could email that to me or Shelly, and we could get that to the Nutrition and Aging Resource Center team to see if we can get that posted or shared in some way.
Sure.
Next is, are these used in a community meal sites as well, or only in the home delivered meal program?
That's also a great question. Right now, just with our home delivered meal program, I find that congregate, maybe if we have like 17 congregate sites, and that one, I'd like to start doing food insecurity there. We haven't branched out with much robust evaluation on the congregate level yet. I would absolutely love to, but I have not gone there yet. I feel like when you go into a congregate setting, they're all with their peers, right? The participants are with their peers. They want to play dominoes. They want to do this. And so even just pulling them away for their annual research, probably a pain to them. I used to go in, and when I first started, I was like, oh, I'm going to change everybody's life. I'm going to present to everybody. And I was just interrupting their dominoes and cards. And I was like, that's not what they want. So that's not a population yet that I have tapped into to evaluate in that way, but that is where I want to go. I think that's the right thing to do. But I haven't done it yet. It's appropriate for that.
It's doable. I did it to validate some tools, and but you have to catch them before or after the meal, because during the meal, that is their socialization. So it took some scheduling. Yeah. We have another question. Can you please speak to which stakeholders might be more interested in malnutrition outcomes versus food insecurity outcomes in your experience, since both have major economic or healthcare impacts? And I can repeat that if you need me to.
No, that's good. That's a good question. I think it depends on the type of funder. So we have certain private foundations, and they're more philanthropic, and they're likely more interested in the food insecurity piece, I feel like, because a lot of, you have to educate your funders. You have to educate your staff, your funders, that food insecurity doesn't mean they're going to be malnourished, and vice versa, and that these are different things. So I think it's learning what is appealing to the funder is what direction to go. I think when I was trying to implement the M&A, there's one funder who's still like our cutting edge, innovative, progressive funder, St. David's Foundation. I have to say their name because I love them, because I was so afraid to make this an outcome. I thought, what if this isn't appropriate? What if this is going to show that we don't do anything? And then this is my metric to a huge funder. When I shared this idea with them, because they are data driven and because they wanted to support this work, they're like, try it. They gave me the permission to fail. And that's helpful. I think where we're seeing right now, there's the philanthropic funding side, which are development angles, but then there's like, we're in a agreement with St. David's is helping us fund it, actually, and with Dell Medical School, the medical school here at UT. Their Factor Health program is all about showing that community-based interventions can lead to a clinical outcome. So they are more likely they're interested in food insecurity, malnutrition, more of the clinical-based things. But food insecurity is starting to be looked at even by health professionals in the clinical setting, realizing that they need to catch this to try to refer out to programs like ours. My goal is, I don't want a referral for the product or service we give because someone is food insecure. I want a referral, and I want them to pay us for the clinical outcome we create. And so that's kind of the research we're working on right now. And I'm hoping that it helps all, or contributes to the evidence base that helps all of us nationally move into this healthcare world. And then our societal infrastructure is not built for the older adults coming in right now, that you're only going to see more and more demand on community-based organizations. So the time is now for us to kind of if you start implementing some evaluation techniques, you can show these people, well, look, this is our data on this. Look, this is our data on that. And even if it's done internally, they might see the value and connect you with the university, or they might say, well, let's do a pilot. I hear a lot of this with the healthcare wanting to do a pilot, and then they can collect the data or whatever. But this is the direction I think we need to really consider going in, because we're only going to be in more and more demand. And if you can build your value proposition now, it's putting you in the right position.
Shauna, we have about 3 minutes. We have one more question, so this will be our last question. And then I have a couple announcements to make to the group. Here's the question. Did you notice any cultural differences in interpretation and understanding when using the M&A?
Another great question. That's actually our next step. We are bringing on a data analyst coordinator, and we are going to sit and look at this because yes, I do think that we are starting to see some of that. I can't say anything conclusive on it right now, but we also noticed from 15 years ago, the type of older adult that's coming on board. We're seeing a lot more food insecurity in the younger old than the older old and all of these things. So that is on our radar. I will say that the M&A was validated in multiple populations. Well, it started in Europe, and then it's even in the Middle East, it's even in Asia. And in Asia, they modified, because the stature of Asian individuals is typically smaller, and so the calf circumference measurement wasn't appropriate, but they validated one for it. So it's really ubiquitously used on the other side of the hemisphere versus on this side. And then the other population it was validated in was a community dwelling older adult population in New Mexico. So because it got to the United States, because it got to community dwelling, I felt good about it. Now, other demographic as far as cultural backgrounds, I don't recall that right now, but that's our next step. Now that the pandemic is kind of in our rear view mirror, thankfully, getting M&A back on track, and then I think we might be more rigorously trying to publish on it. So I think we'll be looking at things like that.
Thank you, Shauna. And I want to thank all of you for taking an hour to hear this wonderful presentation about evaluation and tools that we can be using in our programs and asking those questions. I do ask that you take a few minutes to complete the webinar evaluation. We use these data to inform what we do next and how we can always be improving to better serve all of you. And thank you so much for joining us today. This was recorded, and it will be posted at a later date on the Nutrition and Aging Resource Center's YouTube page. We will share when it's available via our e-newsletter. So thank you, everyone, and have a great day and weekend.